Thank you, Paula, and thank you to the Brazilian consulates, everyone at San Diego State University for putting on this wonderful event in recognition of World Chagas Day and for giving me the opportunity to be here. And it's very special for me that this event bridges Brazil and California and Chagas disease, and to speak after Carolina, who was one of my mentors in Chagas disease, and right before Shiba Memandi, my other mentor in Chagas disease. So I'm very excited to be here today and join you all. Today I'd like to talk for a little bit about the Drugs for Neglected Diseases initiative, what we do in general, and what we're doing for Chagas disease. And just to get a little bit of background, DNDi grew out of Doctors Without Borders from the recognition of doctors in the field that there were important diseases, primarily affecting vulnerable populations for which no good treatment was available. And these are the diseases that were described by Carolina in her presentation. So today, DNDi has a portfolio focused on several diseases which are listed here, including sleeping sickness, leishmaniasis, dengue, and others. And Chagas disease has been one of our focuses since our founding in 2003. And just kind of briefly to review our goals in the column on the right, really are to support the World Health Organization's goal of eliminating Chagas disease as a public health problem. And so we're focused on, one, developing a safer and shorter treatment with benznidazole, also looking for entirely new drugs for Chagas disease, and supporting the reduction of mother-to-child transmission, as has been discussed today already. And this is just a graphic to sort of illustrate the global picture of Chagas disease. We've talked about around 6 million people. But what's happening with them to the best of our knowledge? So a little over 6 million people estimated to have the infection. And of those, there are over a couple million for whom probably treatment with antiparasitic drugs would not be indicated, either because they've already developed cardiomyopathy or had other progression, or because of other contraindications. But that leaves us this group in the middle of about 4 million people who would meet the eligibility criteria for treatment. And now these numbers are a little behind, and that's one of the problems, is we don't have good surveillance or good sources of data on which to base our estimates. But to the best of our knowledge, less than 500,000 of those people have been diagnosed, which would be less than 7% of the total. And less than 70,000, probably a little more now, but still that only represents about 1% of the total, have had access to treatment. And importantly, that only represents about 16% of those who were diagnosed. So there's two huge gaps. Not enough people are getting tested, and if they're not getting tested, we don't know who needs to be treated. And then of those who get tested, not enough are being able to go on and get treatment, which is important to prevent complications from the disease and mother-to-child transmission in the future. So what happens if the current status quo remains the same, if we don't make a change? Well, over the next 10 years, we could expect 75 to 100,000 premature deaths due to Chagas disease, 8 million dailies lost, around 300,000 new cases due to vector transmission and 85,000 due to congenital transmission, around 1 million or more new cases of cardiomyopathy, and about $7 billion in healthcare costs and $80 billion in economic losses. So we need to do things differently, but what can we do to change the status quo? And I'm just organizing my talk today around 5 main lines. There's certainly other items that could fit in here. We really need to improve the current Chagas disease treatment, strengthen capacity in the healthcare system, simplify the testing processes, and improve access to testing and treatment, and then advocate to get our policymakers to support programs to end the neglect of the disease. Why are so few people getting tested and treated? This was sort of a model that we created to explain this in the United States, and we've grouped the barriers into 4 different dimensions. And just really quickly, systemic barriers have to do with gaps in the health system, like we've talked a lot today about low awareness among healthcare providers, or not having the tests available to test people. Clinical barriers is really what's DNDI's focus has been, and that's limitations in our diagnostic and therapeutic toolkits, as well as the complexities of the disease, which I think will be addressed well by some of the following presenters. Structural barriers have to do with political and economic inequalities that put certain populations more at risk for Chagas disease, while also making it harder for them to access the healthcare system for testing and treatment, or to advocate for better availability of testing and treatment. And psychosocial barriers encompass things like the stigma that might be associated with the diagnosis of Chagas disease. So first, I'd like to talk about improving Chagas disease treatment. And these are the words of someone with Chagas disease. I've changed all the names for confidentiality, but in a study in which Center of Excellence for Chagas disease in Los Angeles, Dr. Maimandi partnered. And this person said, in my case, they can't give it to me because it's very strong, and if the medicine were a little milder, I could take it. And that's just a reminder that we have a lot of problems with the existing drugs, benznidazole and nifurtimox. So there's only 2 drugs. There haven't been new drugs in over 50 years, and both are associated with a long treatment period of 2 to 3 months. We don't have a good way to measure the effectiveness of treatment. We don't have a good test of cure. And side effects, something brought up by Myra, is a concern which causes about 1 in 5 patients to have to drop out of treatment. And so there's also an important subset of patients who can't tolerate either drug. And finally, costs. Even though the drugs themselves are not necessarily that expensive, the fact that we have this long treatment period and the concerns about safety means that patients have to get additional laboratory testing and monitoring, and that means costs for the health system. It also means costs in travel and lodging and transportation, things like that for patients. So this is just a graphic kind of illustrating the R&D pipeline, and this is just a way of presenting some of the things that we're trying to work on in Chagas disease. So the R&D process is a long process from the discovery phase to clinical trials, to implementation, which is really focused on how people are now getting the medications that come out of the pipeline. And DNDI's work, we don't do anything alone. So everything I'm talking about when I say DNDI, I mean us and many partners across the world, including patients and communities, ministries of health, academic, investigators. Industry plays an important role, and of course, treatment providers. And so looking at the early phases, I just wanted to mention one of our initiatives has been the Lead Optimization Latin America Consortium, and this is a partnership between DNDI and several institutions in Brazil, which is looking at screening new compounds to identify potential new treatments for Chagas disease. And I'm also, should have mentioned at the beginning, and I'm proud to say that one of our original founding members was the Oswaldo Cruz Foundation. Now I'd like to just give an overview of some of the clinical trials that we have been involved in, recently published, and now I want to talk about what we can do to improve the current treatments we have available, because there was some evidence that maybe we don't need that long of a treatment with benznidazole. Maybe it can be effective in a shorter period, which would then help reduce the side effects. And so the Bendita study was a phase 2 clinical trial. Publication came out a little over a year ago, which showed that shorter regimens of benznidazole could still have antiparasitic efficacy and produced a lot fewer side effects and patients dropping out of treatment. Now it's very challenging to do a clinical trial in Chagas disease because we don't have a very good way to measure efficacy. And so one method was developed and agreed upon by investigators through the Chagas platform, which I'm going to talk about a little bit later. And according to that, and this gives us a way to compare, across different studies. But according to that, the antiparasitic efficacy in shorter treatments of benznidazole was good. And so based on that, we're planning a new phase 3 trial with partners including Mundo Sano Foundation and Elea Phoenix. And recruitment for that is set to start this year in Argentina in several different centers. And this will examine whether shorter treatments as short as 2 weeks or 30 days can still be effective and reduce the side effect profile, making it easier for patients to complete treatment, making it easier for healthcare providers to treat patients. In parallel, we have coordinated on several of the parameters for the trial and the endpoints with another important study which is taking place in Bolivia and Colombia and is being led by the Oswaldo Cruz Foundation as part of the Cuida Chagas project, which is a large regional project addressing congenital transmission for Chagas disease. And the name of the trial is Ben Latino. So between these studies, we should have great evidence in the coming years about the value of shorter treatments of benznidazole, one of the current treatments. But we've also been looking at new chemical entities for Chagas disease, and we ran one of the first clinical trials for a new chemical entity. That was an early activity of DNDi, and the compound we evaluated was E1224. It's important to point out because that trial did take place in Bolivia in collaboration with the Bolivian Chagas platform. Also, an early study of fexinidazole, which was another compound that showed promise for Chagas disease, also took place in Bolivia. The trial had to be interrupted because of safety concerns, so a different dose was tried out in a subsequent trial in Spain. And I just want to be sure to recognize the key partners involved in those studies, CIADES in Bolivia and IS Global in Barcelona. And besides those, I just want to mention there are several other trials which are also exploring similar questions that I don't have time to talk about today. But just to know that there's a network of different people who are engaged in these questions. Sometimes the problem comes that, you have researchers in different parts of the world addressing the same questions and sometimes not being able to connect. And so sometimes they're duplicating efforts or they're just not getting information from each other. And with the limited resources in Chagas disease we have, that's a gap that we can't afford. And so the Chagas Clinical Research Platform was created in 2009 as a way to provide a space for the different researchers in the Chagas community to come together and to share research and ideas and to have discussions. So we do this presentially through annual meetings and workshops, and we also have a virtual space where all of the different investigators and participants in the Chagas platform, which includes patient organizations, community organizations, social science researchers, industry, academic institutions, et cetera. And this is just a graphic showing sort of the global distribution of the around 500 members of that research network. So a second concern is strengthening healthcare system capacity to care for patients with chronic Chagas disease. And this person said, there's not a lot of awareness. I think every health center should give talks about this disease to train the nurses and everyone else because they don't have knowledge about it. So DNDi in different endemic countries has been involved in strengthening health system capacity through different modalities, including training healthcare personnel in diagnosis and treatment. And sometimes this means connecting with experts through the Chagas platform and things like congenital Chagas disease and other factors in order to get them to participate in trainings in the healthcare systems of affected countries. Also, a lot of work updating manuals and recommendations. A lot of us in the United States were recently involved in a collaborative group to put out updated diagnostic recommendations for Chagas disease in the United States. Sheba and Paula were both key in that. and improving information resources for healthcare providers. So another thing that we've developed is an app which healthcare providers can download. It can work offline, and it has information pretty much on everything about Chagas disease. So people who see patients can bring it up on their phone, and if there's no connectivity, there's no problem because it's downloadable. We have that available in Spanish, and we're working on translating it into English and also into Portuguese. And so I just want to thank our volunteer Portuguese translators from MSF USA who are helping with that. We also need to simplify the testing process to make it more accessible for patients. And this person said we should include it in annual physicals or provide the test for free. I would find a way to provide free Chagas testing in more places. So in order to do that, we need to better understand the performance of current diagnostic tools. We've worked with the Ministries of Health in Colombia and Guatemala and other partners in both countries, academic and public, to understand how well the different tests for Chagas disease are performing in those populations, because as Paula was mentioning, there's a geographic distribution to the disease. So tests which work perfectly well in Argentina, for example, may not have the same performance in Mexico or in our population in the United States. So performing those studies and working with those partners to improve the available diagnostic tools. And the next frontier for Chagas disease really is to better incorporate rapid point-of-care tests. If we can give patients a diagnosis as soon as they come in, or at least get them routed into care through rapid tests, it will help us reduce loss to follow-up. We need to improve the overall access to testing and treatment. And as this person said, make treatment more accessible. Thank God we have insurance and we're able to go to this clinic. But maybe if there were more clinics and better informed doctors, it would be easier. And so DNDi recently has developed a simplified access framework that it uses across diseases and countries, addressing 4 main elements: demand, supply, systemic obstacles, and financing. But I also want to point out to, how do we make this work in reality? And in our access program for Chagas disease, we have developed a 4D access approach, and the intellectual author of that, Carolina, is joining us today. And this is really a straightforward and simple approach, which we call the 4Ds: diagnose, design, deliver, and demonstrate impact. But there's a detailed methodology which really points out how we work with health systems every step of the way to implement programs and then to ensure monitoring and evaluation and to retool as necessary. So using this methodology, we implemented a pilot project in Colombia, and again, Carolina was instrumental in making that happen. Initially, the project was implemented in different endemic departments in the eastern region of Colombia. And the impact from the pilot project was by helping to simplify the testing process. There was a 92% reduction in wait times for test results. So whereas before it was taking several months to a year for patients to get results, we were able to get that down to a few weeks. The model that we've used has been scaled up to over 22 other municipalities in Colombia so far, and we've seen a 5-fold increase in people tested per year compared to the baseline year. Now these are baby steps, as Myra had mentioned. So overall, we're still not talking about large numbers of people, but we've got a model in place now, and it's something that can be expanded, and over time, it's going to increase incrementally and make a difference. And another element of this project has been improving access to information for people at risk through the development of information, education, and communication materials, which is also a key need. And I just kind of wanted to put a graphic of our overall Chagas treatment access project. As you can see, the 2 green circles using the 4D methodology We were able to implement projects in Colombia and Guatemala with partners, but we're also involved in Argentina in connection with the clinical trial and planning there. And we also work with several partners across the United States to advocate for more awareness and for Chagas disease, and importantly, to give a shout out to the Center of Excellence for Chagas disease, which she was going to describe next, and also to the University of Florida Chagas program, which is doing amazing work there under Norm Beatty. And finally, we need to advocate to end the neglect. And to conclude my presentation, I just want to mention the Bogota Manifesto. This was a document that was put forth by the Chagas Coalition at the last meeting of the Chagas platform in Bogota, Colombia in September of last year. What this is just a simple document that contains 6 principles, and these are 6 principles that we hope policymakers will embrace in order to end the neglect of Chagas disease and meet the World Health Organization targets of ending Chagas disease as a public health problem. And very simply, it's about improving access through simplified routes of care, especially centering care in the primary health care level, which is central to the message of Chagas Day this year. And secondly, to encourage investment in research and development. We saw from Carolina's presentation, there's a huge gap remaining there. Facilitate access to training and information resources. Promote coordination between all the actors involved in routes of care. Continue to support World Chagas Day as we're doing today. And improve surveillance and control of the disease, expanding systems of mandatory notification and reporting of Chagas disease. And that concludes my presentation. Many thanks.